Thank you all for coming to Wing's oral qualified exam. And then today we have three faculty, and Professor Liang, Professor Zhou, and I will be the committee member. And then Professor Liang will be the chair of this oral exam committee. So I think I will briefly introduce Wing to the committee, and then hand the over the floor to Professor Liang later. And then Wing is from Vietnam, and then he had a he has a background in pharmacy, and then received a master's degree from Cardiff University from UK. And before he came to the IHP for PhD training, and he was an officer in, I don't know whether or not pronounce it correctly. What's it? How do you pronounce the name of the province? Wing?
Dong Thap.
Oh, Dong Tam province. And
Yes.
then the division of the general and social affairs, and then a special assistant to the premier of the province, and handling the matters of healthcare and health insurance. So and now is his third year, and then it's time for him to do the oral qualify. Okay, it's a brief introduction of Wing. And so now hand it over to Professor Liang.
Thank you, Professor Nicole, for your nice introduction to Wing, so everyone get to know Wing more. Hello, Wing. So how long is your presentation going to be? May I ask?
Yeah, I can start now. Yeah.
Okay, so how long are you going to present?
It's around 25 to 30 minutes. Yeah.
25 to 30 minutes. Okay,
Yes.
I will time your presentation, and I will remind you when it gets to 25 minutes. Is that okay?
Yeah, it's okay.
Okay, thank you. Yeah, off you go.
Yeah, okay. Thank you. Share, right? Okay. Okay. Can you see me? Can you see the sharing slide?
Yes, but would you like to make it as a full screen?
Wait a moment.
Okay.
Wait a moment.
Yeah, that's better. That's full screen. Thank you.
Okay. Okay. Thank you for all professor in the committee members attend today for my presentation. Today I would like to present the doctorate dissertation proposal with the title "The Impacts of Co-insurance Reduction on Healthcare Utilization Among Social Health Insurance Beneficiaries in Đồng Tháp Province, Vietnam." My advisor is Professor Nguyen Tran Nguyen and Professor Nguyen Hoang. Before presenting, I already checked the originality on the Turnitin, and its similarity index is 8%. The content of presentation, including the background, literature review, research objective, proposed method, expected result, limitation, and implication. The first part is introduction. There are heated debates on cost sharing. In recent decades, many countries try to adopt health insurance to achieve or move toward universal health coverage. At the same time, there are also dramatically increasing healthcare expenditure, a rise is a key concern for the government. To address the issues, employing cost sharing along with the health insurance scheme is commonly adopted as a demand-side cost containment strategy. The one who supporting cost sharing said that cost sharing will reduce moral hazard. It means decrease in healthcare spending and use by preventing the consumption of inappropriate health services and encouraging the consumption of cost-effective care. In contrast, the other things that increase cost sharing will increase the financial barrier that trade off the financial protection for vulnerable population, resulting in negatively affecting universal health coverage. Another key objective of the government is to generate the revenue. The supporting argument is that cost sharing will improve the budget, guarantee sufficiently drugs and medical supplies, and facilitate quality healthcare delivery. Most cost sharing focus on the curative healthcare to collect more revenue because it's likely to be inelastic and have no close substitute. In contrast, the other thing that cost sharing, the evidence show that the cost sharing generate minor financial contribution to total revenue, and the cost sharing implementation require a complicated administrative system that increase the cost for on the system. The patient also will substitute the health service with cost sharing by other service without cost sharing, and this service may be more expensive. So it lead to increase overall cost. Cost sharing policy are commonly revisited by many countries. Vietnam, developing country, also adopt cost sharing policy since 1992. Vietnam tried to achieve a universal health coverage. So we implemented a social health insurance that currently cover 87% of population. However, the benefit package is limited compared to the more comprehensive package in the high-income country. Vietnam also faced the same issue with the other country, that the rising total health expenditure and is more than double in per capita terms over the period 2000 and 2016, and patients suffer from high out-of-pocket costs that account for 41% of total health expenditure. But unlike other countries, Vietnam implemented a policy of cost sharing reduction in 2016. We go to more detail here in this slide. When buying a health insurance, each enrollee is assigned a main care provider at the time of enrollment by a social security agency. The provider can be the commune or the district or province level. The user are encouraged to visit reassigned provider if they go to the other healthcare facility at a different level or in another district, they will have to pay 30% of healthcare costs. But after the January 1st of 2016, the co-insurance rate reduced to 0%. So it means users are free to choose any healthcare facility at the commune and district level. There's a lot of opinions about new policy. Supporting arguments say that the new policy have to remove financial and administrative barrier for people, especially migrants. It offer more convenience and freedom to choose for the patient. The new policy also expected to attract more people to buy health insurance that promote using primary healthcare and lead to expand health insurance coverage and achieve universal health coverage. In contrast, other things that the new policy will lower the utilization of primary care system while overload burden for district level healthcare facility. It's also increase moral hazard when the patient will abuse service use. And it's also increased transaction costs for patients, such as the transport or accommodation costs when they visit the healthcare facility in the further distance. The new policy also trigger unhealthy competition that the provider may oversupply the healthcare service. The new policy is a hot debate, but then there's no available empirical evidence to add the policy discussion. Now we move to the next part is a literature review. In the literature review, I focus on presenting the empirical evidence of cost sharing. One of the most important empirical evidence is the run-held-run experiment. This experiment is a randomized controlled trial that already proved the existence of moral hazard. The result, the key finding is the participants who have higher co-insurance rates consume fewer healthcare than the control group with zero co-insurance rate. Another key finding is co-insurance decreased healthcare utilization, but did not compromise the health outcome. Those findings give a strong implication for the government to promote a cost-sharing policy. However, there's more study that criticize the result of the health experiment. That the experiment maybe have the selection and reporting bias, that the different arms of the experiment might systematically include the differential participants who report the differential result. The experiment also require further assumption to translate the result into a usable benchmark value. The sample size is also small, it's around 6,000. And the experiment is well conducted in a more simple healthcare system than present one. At that time, the insurance plan is much simple than now, and the technology is less advanced than now. Another critics is cost sharing may affect the health of vulnerable population. The final critics is the experiment select only the healthy population and exclude the elderly people. There's more and more recent evidence about cost sharing. I divide into the four parts. There is the first part at increasing cost sharing and healthcare utilization in developed country. Developed country employ a lot of cost sharing scheme such as outpatient, emergency department, and prescription drugs. The general finding is that increasing cost sharing reduce healthcare utilization, but it may unintendedly affect some utilization of some health service and health spending outcomes and change the care seeking behavior. Now we move to the developing country. First, we visit the country with the high health insurance coverage. In those countries, increasing cost sharing generally reduce healthcare utilization, but there's lack of evidence about unintended effect on other indicators. You can see the number of studies limited here. Now we visit the country with low health insurance coverage. The result is the increasing cost sharing also reduce healthcare utilization, but there's some unintended effect on care seeking behavior. Now we move to the decreasing cost sharing policy in a developed country. In the developed country government, they try to adopt the cost sharing reduction to remove the financial barrier and encourage the use of high value care such as preventive service. The result is a decreasing cost sharing, increase healthcare utilization, but have some unintended effect on other healthcare utilization, change the referral pattern, and increase disparity in healthcare access. Now we move to the developing country that most of the study focus on maternal health care in African country, which have a low health insurance coverage, or in China with the high health insurance coverage. The result is decreasing cost sharing may or may not increase healthcare utilization. It depends on the policy design and implementation. And decreasing cost sharing has some unintended effect on care seeking behavior, and similar to developed country, it's also increased disparity in healthcare access. After reviewing literature, I find some research gap that available study has a inconsistent result about the effect of cost sharing on healthcare utilization. And there's some study that is low quality or conducted in the earlier year, while the evidence is limited on the cost sharing reduction policy in developed country and China, or user fee reduction in African country only. So there are lack of study on the cost sharing reduction policy in developing countries with a high health insurance coverage that motivate me to conduct the research in Vietnam. It is the research motivation that academically my present study contribute to understanding of cost sharing policy in low middle income country. In terms of management, it will have to enhance local health system efficiency and quality, and it also brings public health significance that improve equity for vulnerable local subpopulation. The research objective is to evaluate the impact of the 2016 co-insurance reduction policy on health service utilization on care-seeking behavior among adults and children population in Đồng Tháp province. The recent study need to answer the research question below, that whether and to what extent the health service utilization change among adults and children before and after co-insurance reduction policy in Đồng Tháp province, Vietnam, and has the first point of care among adults and children changed before and after the co-insurance reduction policy in Đồng Tháp province, Vietnam. The third question is if there were changes in the utilization and first point of care, whether these changes differ between rural and urban adults and children. This is the conceptual framework of the study that I adopt from the latest version of Anderson behavioral model of health service use of 2013. We can see here this is the main independent variable is enabling and financing factor co-insurance reduction policy. We also take into account other contextual and individual components such as area of residence, age, gender, occupation, and ethnicity, poverty level, health insurance benefit level, and receipt of any government assistance and comorbidity. For dependent variable is care-seeking behavior, including first point of care and service use spending. Based on the conceptual framework, I propose the method that this is the study setting. The research will be conducted in Đồng Tháp province. It is a province located in the Mekong region along border Cambodia and in the south Vietnam. The province population is 1.68 million, and the province have 175 healthcare facility, 11 at the province level, 19 at district level, and 145 is the commune level. This figure indicate the health insurance coverage of Đồng Tháp province. You can see the trend of coverage is increasing during the period. At the baseline, the year of 2015, there's around 1 million people enrolled in the health insurance, and until the 2019, it increased to nearly 1.3 million people. I obtained the 2015 and 2019 social health insurance enrollment and claim data from Đồng Tháp Province Social Security Agency on a monthly basis. And each medical claim include the healthcare provider IDs, which is pre-assigned at the enrollment and also recorded at the point of care. We also have the health insurance card user ID to connect all of the data. The enrollment and claim data, including contain the information, the demographic information such as year of birth, gender, area of residence, benefit group, benefit level. They also provide the information about outpatient, inpatient, and emergency department encounters, including the date of visit, admission, discharge, length of stay, and diagnose using ICD-10, and specific and total expenditure. The data set also provide healthcare facility characteristic, including its level, ownership, or type. I adopt the interrupted time series for study design that evaluate the effect of the coinsurance reduction policy on healthcare utilization and healthcare seeking behavior. The study period is 5 years from January 2015 to December 2019, and it is 1 year before and 4 years after the policy change. During the study period, there is no major benefit coverage change or insurance policy change. For the study population, I divide into the two cohorts. The adult cohort is social insurance beneficiary age 18 years and above. At 2015, the inclusion criteria is who consistently enrolled in social insurance program from 2015 to 2019, and we exclude the newly insured and the lost to the follow-up who may move to the other province or pass away. For the child cohort, it is the social insurance beneficiary age below 18 years at 2015. The inclusion criteria is similar to the adult cohort, and the exclusion criteria is the children who were born after January 1st of 2015. The main independent variable is the years of coinsurance reduction policy when it's reduced from 30% to 0% at the district level for both outpatient and inpatient. And this policy effective on January 1st, 2016. You can see here at the province level, the coinsurance rate remain unchanged during the study period. Other dependent variable, including the age, gender, occupation, ethnicity, poverty level, health benefit level, receipt of government subsidy, comorbidity, and area of residence. The adult cohort will use one of the independent variable here, but the child cohort only use the ones in the red ink because there's no availability of the other variable. The dependent variable are divided into the two groups. The first group of dependent variable is healthcare utilization, including the number of encounter for outpatient, inpatient, and emergency department. The length of stay for inpatient admission, the drug and total expenditure of service for outpatient, inpatient, and emergency department. The second group of dependent variable is case-seeking behavior. It include compliance with primary care provider designation. It is the first point of care would be compared with the pre-assigned healthcare provider before and after the policy change. If there are larger difference, it means that more the patient have more freedom to choose the healthcare facility. The second one is the first point of care that will be analyzed depends on the level, the ownership, and the type of healthcare facility. The last one is the referral pattern. It includes the self-referral, appropriate referral, emergency, and connected referral. For statistical analysis, the data will analyze 1 year baseline with 12 observation on monthly basis and 4 year follow-up with 48 observation. And I will conduct the descriptive statistic for on variable and run a segmented regression equation to identify the coefficient. Regression analysis would be conducted separately for rural and urban residents. In the software, SAS version 9.4 will be used to analyze the data. Now we move to the last part, expected result, limitation, and implication. For the expected result, I will draw a line chart to illustrate the trend by month for dependent variable similar to the example here. For the table 1, I will present the baseline characteristic of the study population in January 2015. For the table 2, I will present the equation coefficient which indicate the effect of coincidence reduction on each variable. Limitation and challenge of my study that my study maybe have a trait for internal validity. It is history bias that maybe there are others concurrent events or intervention or policy that may compete with the main independent variable in the effect on outcome. The second trait for internal validity is a time varying confounder that among the factors in the conceptual framework. The other factor is more stable, but the poverty level and comorbidity could be changed over time. So it requires more effort to address. Regarding the external validity, is more difficult to generalize the result of present study to all of the population of province because we already select the healthier population who consistently enroll in the social health insurance to best capture the effect of the policy of interest. And we exclude the health service user without health run or with health run but visit healthcare facility in nearby province. The result can be generalized to the Mekong Delta region, but it should be careful to generalize to national population because different demographic composition and social economic condition. The policy implication of the present study in low middle income country, cost sharing reduction mechanism can be used by policymakers to encourage healthcare utilization or influence care seeking behavior. But there may be unintended consequences such as rural and urban disparity. It shall not be overlooked. And the present study will provide empirical evidence to policymakers in low middle income country for future planning or modification of their cost sharing policy. Thank you very much for attention and welcome for question.
Thank you, Nguyen. I think you have kept the time constraint very well, and it seems that you have a very ambitious proposal, which is very impressive.
Thank you.
And your presentation is very clear. So how should we proceed? So it seems that I'm only external committee member. Okay, so I guess I should get started, and then I will invite Professor Nicole and Professor Joe to give you comments. And yeah, first of all, I think you have identified the research gaps very clear, and I believe this research will contribute to academia research and empirical studies. And the second advantage is that you have a very rich data sets. It looks similar to Taiwan's national health insurance data sets to me, because you have detailed information on patient comorbidity, utilization, and characteristics of medical institutions. So that allows you to control for a comprehensive set of confounders. And then you have many Y variables. I can see that you want to investigate care-seeking behavior, healthcare utilization, and then under each category, you have different variables. So overall, I think the proposal is comprehensive and the conceptual framework is reasonable to me. So I have, based on your presentation and your written proposal, I have several questions. The first one is that for cost sharing reduction, it seems that there are different levels, right? Because
Yes, different level.
yes, you mentioned that you will focus on the district level, which reduced the cost sharing from 30% to zero. It's
Zero,
almost
yeah.
free. Yeah.
Yeah.
And the policy was introduced in 2016, the 1st of January. So since there are different kinds of cost reduction policies under this broad umbrella, would you consider using all of these variations in cost reduction policy to identify the effect of the policy? Would you mind going back to the table with detailed information on cost sharing reduction policy?
Which one?
Not
No,
this
no.
one.
I think this one, right? The main variable, right? This one.
Yes,
Is
yes,
it?
yes, 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 this one, this one.
Yeah.
So for outpatient, only district level changed, right? And
Yeah.
so it makes sense to look at the district level. And
Yes.
for inpatient, oh, it's also district level changed. But I was
Yeah.
wondering, there's a missing column in commune. So it seems that they don't admit inpatient, right?
The commune level health station, they don't have the best, so they don't have the inpatient service. So
Okay.
yeah.
I see, right. And so is there any variation in the target of cost reduction policy? Is it universal for everyone enrolled in the insurance?
Yeah, it's the universal for all of the people, for all of the beneficiary. It's the level. It's based on the levels. Yeah.
Okay. How
It's
about
not based on
the vulnerable groups? Do they also pay part of the medical cost prior to the policy change? Because, for example, in Taiwan, a patient with the major illness card automatically exempt from copayment. So is there any different cost sharing policy across populations before introduction of this policy?
You can see here they have another cost sharing here that the health insurance benefit level is based on the benefit package. For example, for example, the poor and the near poor here, they also have the different level. But I try to choose the study period that the health insurance benefit level here is stable. It's not changed during in terms of the policy during the study period. So the other cost sharing, there also some different cost sharing for different vulnerability, but it's not changed during the study period. Yeah, so it's stable. And
Okay.
I will specify on the vulnerable to observe the effect of the district level only.
I see. Okay, I was just thinking if there's any possibility to find a comparison group.
Yeah,
Yeah,
I
because
know.
I think time interrupted series analysis is reasonable for this research. but a potential limitation is that there's no comparison group under this methodology framework. And but I have to say this method has been widely applied in empirical studies, so I think there's no problem at all to apply this method. Okay, and so that is my first question. And I think that's fine. If it is not possible to find a comparison group, it is okay. And the second question is, it seems that there was an increase in insurance coverage in terms of the population covered during your study period, right? From 2015 to 2019.
Yeah.
Yeah.
Please.
Yes. So you're going to exclude newly enrolled populations and only focus on those that was already enrolled at the time of 2015, right?
Yes.
Okay. And I think it is okay to do so. But I was just wondering, because during this period, more and more people got insurance. They're from like have to pay totally 100% out of pocket toward like paying only part of the medical cost. And then if they enrolled after the policy, the cost sharing reduction policy was introduced, if they enrolled after 2016, and they will automatically like eligible to the free medical care, right?
Yes. Yeah. At district level. Yeah.
Yeah. So I think this is a big change for this group, because they're from paying 100% to paying 0%.
Yes.
And in some sense, I think it may be interesting to see this effect as well. But of course, it depends on how you define cost sharing reduction policy. I think it is a relevant but a different issue, but maybe it worth investigating. So another related topic is looking at people enrolled in different point of time during your study period. For those enrolled earlier, they will have to pay 30%, and for those enrolled later, they will pay 0%.
Yes.
Yeah, and I think if they represent a large proportion of the population, then maybe you can explore this change as well. But it depends on how many people were newly enrolled during your study period.
There's around 300,000 from 1 million to 1 million, 1.3 million, so 300,000 new enrollee during the period.
Okay.
Yeah, but like I have no information to identify the utilization before the policy.
Okay, I see. Yeah. Okay, I see. And so in that case, probably you will also consider looking at the expansion of health insurance coverage on the healthcare services, because when more people were insured, I suppose they would visit clinics or hospital more, and that would probably affect the supply of healthcare services. It's not from the demand side, but maybe it will also affect the supply side if the capacity of hospital is limited. And so I think they maybe have some effect on healthcare utilization in the equilibrium. Okay. And my last question is the analysis is for one single province, and I understand that could be a limitation. But I was just wondering if the province representative of most of the province in Vietnam, if it is representative, like it's a typical province that look similar to other province in Vietnam, and in this case, if you focus on a representative province, I think the generalizability could be justified in some case.
Yeah.
Okay.
Basically, Vietnam divided into the 6 regions. From the north to the south is very scattered, and my province are located in the southern. That they call the region is the Mekong River region in the south. Here, most of the province here they share the similar demographic composition and the socio-economic condition and disease burden as well. It can be representative for Mekong River region, but for the other region, due to difficult in availability of data, so I can only focus on this region. So the result can be generalized for this region, but should be careful to generalize to the other region. Yeah.
I see. Yeah. So only if it is only for one province, I think this study is still valuable.
Yeah.
Yeah. Okay. I think that's all from me. Thank you. And so, would Professor Nicole and Professor Joe like to comment on Nguyen's proposal?
I think Professor Joe should go first.
Okay, sure. Ian, I think you did a good job, and you already fulfilled my expectation. As a doctor student, you should be able to find an interesting question, and then you can find a data set to answer this question. I think this question is quite interesting. For the low income or developing country, we really need more evidence about the cost sharing policy. So I encourage you to do this dissertation. However, I have 2 questions. The first one, when we look at the RAND experiment, and you know, RAND experiment is so important because they not only look at when you increase the copayment and the utilization will decrease. You know, you pay more and use less. You pay less, you use more, right? And it's quite obvious. And the most interesting part is they look at the health effect. You know, so far, if you use more or use less, at the end, we would like to know what's the impact on people's health. So because you already have the claim data, is it possible for you to figure out is there any indicator can be generated from the claim data and you can measure the health outcome? That's the first question. And the second question is you try to stratify the effect by rural and urban area, right? And I think you may need to say more about the rural and the urban area. From my point of view, it probably more important is the supply side effect, because people want to look at the demand and the copayment policy, how they interact with the supply side effect. I mean, if there is more hospital, more physician, does it have different kind of copayment effect? That's quite important. And if you only say rural and the urban, it represents many things. For example, probably there is more rich people live in the urban area, right? Or there's more hospital, more physician in the urban area. So my suggestion is it possible for you to gather more information and can look at different region, like by different market area, to calculate and their hospital bed, physician numbers, or even the Herfinda index, and you can use it and test different kind of hypothesis. That's my question.
Yeah. Thank you, Professor Châu, for comment. For the first question is about any variable or any column in the dataset that can be used. I'm thinking about that to evaluate the health outcomes. So I have the one column is about the comorbidities. So ICD-10. So the number of disease. So the number of disease, if we observe over the time, we can see that we can identify some severe disease that if increased, so the disease burden may increase or reduce. So I think it's possible to use the ICD-10 code to identify the disease burden and the health outcomes that is influenced by the cost sharing or not. For the second question is about the supply side. For the hospital, like you can see that we have 175 hospital, and I can obtain more information about the number of beds or the healthcare professional, like to see to dig deeper on how the whether or how the healthcare provider or supply side can meet the demand, the rising demand of the healthcare caused by the cost sharing reduction. So maybe I will dig deeper on the number of beds and something. I will stratify based on the number of beds or something, not only based on the level. Yeah.
All right. Professor, fine.
Okay, and then thank you, Professor Liang and Professor Zhou for the comments and questions. I think Professor Liang and Professor Zhou are trying to help you to make your study better and to get more insight based on these valuable data sets. And then I guess you are probably the first students in IHP who can acquire a data set like this for your thesis, because a lot of time it's very difficult to get access to such data sets like the one in National Health Insurance in Taiwan. So I believe that the data set is not, you can use it once you know how to use the data set and to do the research. I think even after you graduate, you can continue to use this data set and to do more research. Okay, so the work and the efforts, I know it's very challenging because it's like over 1 million healthcare claims enrollment data for over 1 million people. So for people who just start to be familiar with the data set, it's very challenging. Okay, but I think all the work will pay off at the end. And then I think Professor Liang mentioned a very important point, and we did try to see if we can find comparison group, and instead of just doing interrupted time series. But it seems that it's very difficult. And then so Wing will try to do the interrupted time series first, and then we'll try to see if there is any other, like any group that we can use. And I believe that the health benefit level, and then or we can dig in more on the different benefit status to see if there's anything we can use. And then also that I think both professors mentioned about if we can try to use a smaller district or areas and try to investigate the potentially differential impacts of the cost sharing reduction policy. I think that's the reason that I first suggest Nguyen to stratify by rural urban is exactly the motivation is exactly the same as what Professor Zhou says, because we believe that, and also Professor Liang mentioned that the maybe the utilization will also be impacted by the capacity, right? So when the cost sharing reduction policy implemented and the demand increased, but the actual utilization may not increase as much because the capacity of the providers. So that's why we propose to stratify the analysis by rural urban. But actually, I think Professor Chou's proposal is even better. That is, it's not just rural urban, because rural urban may represent different multiple factors. Okay, if we were just stratified by medical resources, then the implications and or the results can be interpreted clearer. Okay, so to what we to what we want to investigate. So I think these are very good ideas, and then we need to see how we can construct these variables instead of just rural urban. That's an easy way we think that we can do, but we can do it more delicately. So that'll be, and then also that I believe that we did a very thorough, very long literature review in a proposal, and but I think that when we were preparing for the manuscript, we need to have more concise, more concise literature review, and then so, but the one that you did for the proposal can serve as a base, for your final dissertation, and that's all from me. And so, thank you.
Thank you, Professor Nicole and Professor Zhou. So what would be the next step for?
Okay. Normally people will ask if there's any further the second round of the questions.
Okay. Is there any second round of questions?
No, I don't have any question.
Okay. And then next, maybe is there any questions from the floor, from the audience? Okay, it doesn't seem to have any. And then we need a separate room for us to discuss the outcome of the qualified exam. So Sue, could you help us? Okay.
Yes.
还没看到哎。
好，稍等哦。
好好好。哎，我记得从前不是下面这有一个什么门进去还是这样？
对，可以。
啊。
这个人稍等一下。
好。
我们在讨论哎。
Hello, everyone. Hello, Wen. Congratulations.
Thank
After
you.
our discussion, we decided to give you a pass. So,
Thank you.
you may proceed with your data analysis. And I believe that Professor Joe and Nicole will give you very good guidance and wish you all the best.
Thank you very much.
Congratulations, Wing.
Congratulations.
Now we need to start the work. Okay, the hard work just begins.
I know. Yeah.
Okay, so and can we? I'm sorry, Dad. Can we take like 5 to 10 minutes break? If
Professor,
both,
we need to take a photo first.
Oh, okay, good. Okay.
So everyone, please turn on your camera. Okay, so I will take the first one. Okay, 1, 2, 3. Okay. And the second one. 1, 2, 3. Okay.
Thank you.
Thank you.
Thank
Thank
you.
you very much.
And yeah, and then Professor Liang and Professor Zhou, and can we take 5 to 10 minutes break?
Yeah, sure. Let's
Then we
take
can-
five,
then we can
10 minutes break. 10 minutes break.
10
Yeah.
minutes break, and then we can proceed with Arnat's oral exam.
10 minutes
Thank
break.
you.
We will
Okay, thank you.
contact 10 minutes.
Yeah, 10
Okay.
minutes. See you later.
Okay, see you. Okay, we will stay in the room. Okay, just turn off the camera and microphone. Thank you. Hello.
Hello.
Hi. So
Hi.
okay.
好，准备好了哈，ready。
哎
好，Professor Huang, Professor Liang, and I think Professor Huang, would you like to introduce your student?
Sure. And then the second session for today is the oral qualify of Arnat. Arnat is from Thailand, and then he graduated from I think from he had a Master of Science degree, right? From the has a Bachelor of Science degree in General Health Sciences, majoring in mental health, and then also from the university in Netherlands, and then obtained and acquired his Master of Science degree in Health Security, Financing, and Management in Thailand. And before he came to Taiwan, and I think he worked for the Social Health Security Office, right, Arnat?
Yes.
And Social Security Office in Thailand. So it's just like the National Health Insurance Administration in Taiwan. Okay, and then so he has always wanted to conduct research on healthcare system, particularly because in Thailand has multiple payer system. They have a universal health coverage, but instead of having single payer, they have multiple payer. So that's his interest in trying to understand better how healthcare system performance under the multiple payer in Thailand. And so that's why he proposed to have to do his dissertation on the topic. And that's a brief introduction of Arnat. And then back to Professor Joe.
Anna, how do you plan to do your presentation? How long?
Like approximately 30 minutes.
Okay. When you are ready, you can begin to do it.
Okay. Thank you so much, Professor Nicole, for the introduction and for all your guidance. And thank you, Professor Joe and Professor Liang, for being my oral exam qualifying committee today. And today I'm going to present my proposal entitled Health Service Utilization, Private Insurance Purchase, and Out-of-Pocket Spending under a multi-payer universal health system, the example of Thailand. And okay. This is the outline of my presentation, consisted of 6 sections: the introduction, research gap and significance, research objective, and the research method. And also the strength and limitation of my study. And I also would like to talk about possible policy implications in the last section. And it is undeniable that universal health coverage system, or the USC, is the global agenda. Like many countries are considering major reform to their health insurance system, and they would like to achieve universal health coverage someday. But selecting between a single and multi-payer system has been a critical decision for policymakers that need to be made. And a single payer system, it has one financing agent, typically the government. They will collect and pool the revenues and purchase the health service for the population. The countries that adopt this system are Greece, Hungary, Korea, Luxembourg, Canada, including Taiwan. For the multi-payer system, Thailand adopt this system, and in this system, you have more than one financing agent. The countries that adopt this system are, for example, Germany, the Netherlands, Switzerland, France, and Japan. And in comparison with the single payer, major concern regarding multi-payer system are potential disparity in terms of financial risk protection and healthcare access and quality. And despite diversity in design of healthcare system around the world, there are three main governance principles in design, and I try to review and synthesize the evidence based on these three principles. The first principle is equity. In comparison with the single payer, the multi-payer will provide diverse benefit package as people may have different needs or preference. And for the disadvantages of the multi-payer, it has a bigger control over in provider pricing and provision behavior, and there is inequity in terms of financial health access and utilization. The second principle is financial risk protection. The multi-payer, there is a market competition which allow for innovative reform. And if private payers are allowed to take part in this system, there is an additional financing sources for healthcare system that we can generate. And particularly is attractive to low and middle income country with weak taxation system. But there are some weak points of the multi-payer system in terms of financial risk protection. There are bigger risk pooling functions and prone to adverse and variable selection and prone to fragmentation in insurance coverage. The last principle, the efficiency and quality in multi-payer system, because there is a competition among insurers, so they may stimulate innovation in healthcare. And we observe that there is a short wait time for services receiving, but there are cross-subsidization and cost shifting among insurers, and there are also bigger purchasing power, and the insurer are less likely to promote preventive healthcare, and there is high administrative cost. And the major concern that I mentioned before is disparity in healthcare access and quality. And according to the because there are both side advantages and disadvantages of multi-payer system, so we try to review and synthesize the existing empirical study focusing on three major issues: the healthcare utilization, the ownership of supplementary private health insurance, and out-of-pocket payment. In terms of healthcare utilization, we found that in developed country and developing country, the higher benefit coverage, the higher utilization. But there are the relevant evidence only limited to the United States and China, and this is limited understanding and inconsistent evidence were found. So we would like to know if the benefit coverage among different public insurance types and its impacts on healthcare utilization. And the next point is that the ownership of supplementary health insurance in multi-payer system. We found that in developed country, the people purchase supplementary private insurance to cover extra billing, and there are those who have supplementary insurance, they will have higher probability of visiting a specialist. While in the developing country with our universal health coverage, they use the private insurance or supplementary health insurance as a tool to broaden the insurance coverage. But there is only limited understanding of demand for and factor associating with ownership of supplementary insurance and its impact. And we also would like to know people perspective toward the benefit coverage among different public insurance schemes, because there is no study on it. And we would like to know, are there differences in purchasing supplementary insurance? And how about the out-of-pocket spending? Out-of-pocket spending, even in developed country like OECD country, approximately 20% in this country spend their own money on healthcare services, and the poorer household still be disadvantaged and experience catastrophic health expenditure. And there is limited evidence available on the extent of out-of-pocket spending on healthcare access and utilization, particularly in developing countries. And I would like to introduce about the Thailand context in terms of healthcare system. In Thailand, the public health infrastructure and healthcare professionals are administered and regulated by the Ministry of Public Health, and the organization of healthcare providers range from primary care unit to hospital. Like at the lower level, we have primary care units as a front line of healthcare provider, and at the higher level, we have hospital at the community level, and the highest level of healthcare is we can find it in the provincial level, regional level, and university level. And as sorry, I think so okay, like here I would like to this figure show you the scheme beneficiaries. Like in Thailand, we have 3 health insurance schemes, as Professor Nico introduced before. Like we have the CSMBS, this is for the government, and the SSS is the mandatory scheme for the private sector employee. And for the UCS, the majority of Thai population belong to this scheme. And you see that 80% of the CSMBS and SSS, these 2 schemes, like 80% of them are rich people. And for the UCS, like 50% of beneficiary under this scheme are poor. And how about the provider payment method? The provider payment method, they apply different payment mechanism for different schemes. And the concern is that under the governmental scheme, the CSMBS, they use the fee-for-service system, like fee-for-service, like they use fee-for-service for outpatient care. And concern is that provider may provide unnecessary care to earn more money from the patient or from this scheme, because like if you work more, then you can earn more money according to the payment mechanism. And how about the study in Thailand? The study in Thailand, we found that after the implementation of the universal coverage scheme in 2002, the number of uninsured fell substantially, and the use of healthcare at health center and at community level increased among lower income groups. But previous study is limited to compare the performance of 3 public health insurance schemes. So only one study was done, and in terms of supplementary private insurance, only one study was done and indicated that private health insurance had a limited role in Thai health system, and there is no evidence filed with respect to the ownership of supplementary private insurance in Thailand. In terms of out-of-pocket spending, we found that the out-of-pocket spending was reduced but remain an important issue in Thai health system. Hence, we need an up-to-date information to inform the policymaker. And what we found in general is that the existing study commonly reported the overall rates of healthcare access and utilization, all focused mainly on one specific insurance type. So there are limited evidence on it. So we try to obtain or conduct a study to find more information regarding this issue. And here it's kind of a recap of research gap and significance of this study after reviewing the literature. The first point is that there is limited understanding of potential differences in health service utilization, private insurance purchase, and out-of-pocket spending among public insurance in developed countries, including Thailand. And healthcare disparity study in Thailand mostly less consider influencing factor or contextual factor and insurance status, and the potential policy implication for health and healthcare equity can be established if disparities are exited, and then we can close the gap in health outcome between the rich and poor. Due to the differences in benefit package, financing, and payment mechanism among the 3 public health insurance schemes in Thailand, to what extent the 3 schemes are responsive to health need and to address financial risk protection remain unclear. So we would like to compare the demographic, socioeconomic status, and health status among people aged 45 years old or above enrolled in these 3 schemes in 2015 and 2017. And we would like to know the determinants of it. And also, we would like to examine the differences among 3 types of health insurance in Thailand. And we also would like to detect any change in potential differences from 2015 to 2017. Okay, let's move on to the research method. But the study design, according to research objective, both cross-sectional and retrospective cohort design will be used in this study. And for the data source, I'm going to use the Health Aging and Retirement in Thailand, or HART. It's the only one a longitudinal panel study survey project in Thailand up until now, and we are going to use wave 1 and wave 2, like wave 1 in 2015 and wave 2 in 2017. The 2 waves are available for public user. And the 2-stage stratified random sampling first the household was selected, and then one representative of the household member is 45 years old or above will be chosen to be interviewed. And like in the first wave, there were 5,616 representatives were sampled from the national household in across Thailand, like from 13 provinces, from 5 regions, and Bangkok and Vinnytsia. And the study sample, why I focus on the 45 years old or above, because Thailand experienced like the higher number of elderly population. So like we would like to prepare to deal with the aging society, and we also experience the decline in fertility rate. And we are going to be the super age society very soon. And we have 3 dependent variables. The first one is health service utilization. We have outpatient and inpatient. For the outpatient, the question that the respondent were asked is, in the last 2 years, did you visit the following type of medical facility? The outpatient department, local health station, and private clinic. Like they have to say like yes or no. And the follow questions is like how many times they visit those outpatient facilities. For the inpatient care, like were you admitted to hospital in the last 2 years, and how long did you stay in the hospital, and what type of the hospital? According to the hospital level, we will construct three measures to reflect people inpatient service utilization and care-seeking behavior. The first one is that any use of inpatient care. The second one is hospital length of stay in the last admission. And the last one is the level of hospital. And for the ownership of private health insurance, there were 3 questions. Do you buy any private health insurance? And how many health insurance policy do you have? And why did you buy a private health insurance? To explore the reason for private insurance purchase. And for the third variable, out-of-pocket payment, the questions were how much in total did you pay for your hospital visit and clinic visits? This is for outpatient care. And for the inpatient care, how much did you pay for your last hospital admission? And for the out-of-pocket payment, we will construct in both ways, dichotomous and continuous. And so the main exposure in this study, there are the 3 health insurance type, the UCS, SSS, and CSMBS. And we also try to control the covariate. And there are some more variables to be considered in this survey. And this is how I construct my variables. For the demographic characteristics, like I have 3 variables. Age group, we have classified into 8 groups. We have sex, marital status into 3 categories. We have socioeconomic status. We have 2 variables here, household income and education level. We have health behavior. We have exercise and smoking status. And for the health condition, we consider physical health status and chronic condition. For residential area, we have 6 residential area. And this is my analytical framework. On the left-hand side, the health insurance type will be the main exposure. And we also try to explore the association between the covariate and our dependent variable. And we will classify them by the insurance type. So the health insurance type, we would like to see if the health insurance type is the moderator in this study. And for the statistical analysis, we will start with descriptive statistics to describe the baseline demographic information of the sample. Then we will use the logistic or linear regressions according to the research objective, and to see the single association and the dependent variable. Then we will apply the multivariable regression for adjusting association. For the cow data, we will apply the Poisson regressions. And for the effect measure modification, I will stratify by health insurance type. And here are the strengths and limitations of my study. Like this study is kind of making it possible to study the role of social health insurance in terms of performance in relation to access to care and financial risk protection. And because hard data set collect rich individual level information that would not be commonly available in national claim data set or administrative data, such as education, income, and health behavior. So it's kind of, we can maximize the utility of hard survey. And like the health system can be measured in multidisciplinary dimension, and the result of this study may be generalized to the larger group of Thai population, age 45 years old or over. And there are some limitations that should be aware, like because of the study design is a cross-sectional study, so we cannot draw the causal relationship, and it is difficult to draw conclusion whether the differences among three schemes enlarge or narrow, because there are just only two waves of data set, and maybe our findings is prone to residual confounding, and because of the survey based on the cell report, so maybe it may be prone to recall bias. And possible policy implication. We hope we can offer references to policymakers for reducing disparity and enhance risk protection through more effective design of our health care system. And we hope we can inform policymakers for the role of private insurance in Thailand universal health coverage system, and we hope we can show that the supplementary insurance and out-of-pocket spending might be used as the possible mean or alternative strategy to address health system challenges. Yeah. Thank you so much, Professor and audience.
All right. I think you do a good presentation. Professor Liang, would you like to ask the question?
Yes, thank you, Professor Zhou. So thank you, Arnold, for your nice presentation. And I think your presentation is clear, and you have covered detailed information on the three public health insurance that you plan to investigate. So I was wondering, I have more like questions instead of comments. The first question is, what would your hypothesis be in terms of doing stratified analysis for the three public health insurance? Because I think the answer to that question would relate to the importance of this study. For example, why looking at different public health insurance type is important? Because you would like to examine the purchase of private health insurance, out-of-pocket payment, and healthcare utilization associated with individual public health insurance. And I guess that you may expect there are different associations. So what would be your hypothesis? Like, would you expect the government insurance, the CSMBS enrollees were more likely to purchase private health insurance, or the SSS enrollees? I mean, maybe you would like to emphasize on the differences between these three health insurance. Like, is it because the benefit package is more generous for one type of public health insurance than others? And so for a narrow benefit package, people may see the need to purchase additional private health insurance, or because the I don't know, maybe other reasons like would make the outcome variable differed across three public health insurance. So I think probably it would be helpful to provide a comparison across the differences of the three insurance instead of the in terms of the benefit package, the premium they paid, the covered population, etc. So any different characteristics that would affect the outcome variables are worthy of a summary. Okay, that is my first question. And then the second one is because the study will focus on population aged 45 and over, and the justification is that the Thailand population is aging. I mean, is there any other reason? Because if this is the reason, then I don't see why 45 above age group is the most appropriate. Because if you would like to consider the aging population, then probably another way to do it is to look at the association between outcome variables and public health insurance type across different age groups. I don't know. Maybe you need to consider more about why focusing on using the 45 years old as a cut point for your target age group. And then another, my last question is, we'll be looking at the health outcomes across the three public health insurance. I mean, perhaps in terms of policy implications, the design of individual public health insurance is important because different insurance design would affect the outcome variable that you investigated, and those outcome variables would probably ultimately affect the final health outcome, like mortality rate, something like that. Yeah, so I think you have a very ambitious proposal, and there seems to be more that you can dig out from the data set, the survey. Yeah, that's all from me. Thank you.
Do you want to answer the Professor Diang's question? No.
Yeah. Can you see my my screen? Because like it's
Yes.
okay. Okay. For this one, like for the first question, because there are different like there are different characteristics of these three health insurance scheme, right? Like the scheme nature, the target population, and also the like how many items of the benefit package that is covered. For example, here you will see that the medical device for the UCS is covered like 270 items, and the social security scheme like 88 items, and for the governmental scheme like it's covered the most of the services. And so because of this kind of difference, I hypothesize that the civil servants and the social like the governmental scheme, people are more likely to purchase a supplementary private insurance scheme to cover some extra billings, for example, the room for inpatient care, because they can afford. Like some other reason for the UCS, if people would like to pay for the room by themselves, they cannot use or utilize their right anymore, so they cannot rely on the insurance anymore. They have to pay like the full amount of services. So, and there are also poorer, like there are more poor people in this scheme. So I think like the governmental scheme, they are more likely to buy supplementary insurance scheme. And for the social security scheme, even though it's cover like less item, medical device item, or some other aspect, but because of they are more healthy people, and most of them are aged from 15 to 55, and after that they still can enroll in the scheme, but not many. I think because like they still in the labor market, so they are more likely to purchase extra or additional private health insurance. Yeah, and wife 45 years old, like because actually this survey try to collect the information from this middle age group, because they would like to see the health seeking behavior of people who are near almost being elderly, because like, okay, how they prepare for themselves for being elderly, for being older people. And because of like if we focus on the, how to say, like in older age group, the information about the social security scheme will not be there, because people will be enrolled in this scheme when they work, and when they were 15 years old until 55, and after that they can decide to opt out from this scheme to other two scheme. Like for example, if their family if their child is a government officer like me, my parent will be follow my, they will have the right to utilize or entitled to the governmental scheme. So I think it like if we can find some evidence from this age group, then we can prepare some policy for being age society for our country. And for the health outcome, I also would like to explore this issue, because but unfortunately in this survey they collect only the let's see here, they collect only the physical health status, and some other health outcome like the disability level or some mental health problem. But I'm not sure if it's relevant to compare this kind of health outcome, because it's self-report. So it kind of, how to say, difficult to find the objective measure for the health outcome. So like here, the physical health status like is based on self-report, and they have to range the score from 1 to 100 to indicate their physical health status. But I'm not sure if we can use it as an health outcome or here the chronic condition. Like we don't know if it occurred before or after they enroll in any health insurance scheme, Professor.
Thank you very much, Arnold.
All right. My question, can you bring to the slide 12?
12. Okay, this one, right?
12. Yeah, this one. Yes,
Okay.
yes. From my point of view, it looked like quite obvious. You have two public insurance schemes, and CSMBS is for the civil servant, and the other SSS is for the private sector, right? Those who is in the formal labor market, so they get the, it looks like the rich people already enrolled in these two kind of the public insurance scheme, right?
Yes.
And those who are poor or dependent probably is in the UCS, this kind of scheme. And I would suggest you to provide more information about these three kind of insurance. It looks like different kind of insurance already cover different kind of the people, and lots of the result maybe can be explained by your this slide. It's quite important. This is my first comment. And please go to the slide 19. I think in your proposal, and this part is I worry about I worry about a lot because your dependent variable, the measurement from my point of view is not quite accurate. For example, if you look at if you try to review the literature of recall bias, and you may find it's quite difficult for people to remember how many physician visits in last 2 years. Even it's quite difficult for you to remember for the last 2 or 3 months how many physician visits, right? And it's easier for people to remember, do you have inpatient care? Unfortunately, in this survey, only asks you, do you admit or not? It's not so accurate. If you ask people how many inpatient care in last 2 years, probably people can give you the right answer, right? So that's I know it's quite difficult to get the data to do analysis. But from this slide, you probably need to do some preliminary analysis to know your data first. Otherwise, when you do the analysis, I think the information probably may not fit to your hypothesis or what you plan to do. This is my two suggestions.
Yeah, thank you so much, Professor. I'm so thinking about the accuracy of the information regarding outpatient care and inpatient care in the last 2 years. Like, it's so difficult to get the accurate or correct information on it. But I will try to check with the like some information from some research institute in Thailand, according to the how to say the visits per person, like per year, so that I can compare the result. Like if it's too high, maybe it kind of bias, or is it too low or something like that. So I will try to compare with the existing data, but maybe it's not
You should do that.
updated. Yeah. Thank you so much, Professor.
Professor Huang.
Okay, I think thank you, Professor Liang and Professor Cho for the constructive comments. I think both professors identify a major thing that we need to work on is try to clearly describe, identify, and distinguish the benefit coverage or major differences across the three public schemes, which may lead to potential differences in the three major dependent variables that we are going to observe. So I think that Arna, you have done some, but it's still not very clear yet. So we need to work on that. And secondly, I know both Professor Zhou and Professor Liang also identified that the dependent variables, and because of due to the data limitation, that so these are probably all the potential dependent variable we can use. But among these, I would think that possibly that healthcare utilization might be the least accurate one. And then I think the out-of-pocket, and then also the procurement of private insurance might be more promising in publication. So and then I think Arnat has acquired the data set, right?
Yes.
And then we are trying to be somewhat conservative, and because we haven't had any experience with the data set, so I suggest that Arna first to try to use the wave 2, the most recent wave, the 2017, and if it's possible that because it is a panel data, so we can try to explore, like, although there are only 2 years difference, but it's because of the middle age adult, and we have elderly too, so we can try to see if there's any change over time. But I think we'll try the cross-sectional first, and to be more familiar with the data, and then continue with the panel data analysis. And but I still think that trying to do the data exploration might give us a better idea how we can go about to approach the topic. And then whether or not we need to analyze all the dependent variable, and we need to depending on the quality of the data, we may not necessarily need to analyze every dependent variable we propose here, and only the one that with the valid data that will we will include. Okay, so I think that the next step we need to do is to try to explore the data sets. Okay, that's all for me.
Thank you so much, Professor.
All right. So we need to go to another room.
A separate room.
Okay.
Yeah.
Hi, Anna.
Thank you, Sue.
Congratulations.
Thank you, and sorry for bothering your holiday.
It's okay.
It's Rihanna.
Thank you, everyone.
From TMU.
I'm done.
Professor Joe, you need to turn on your microphone.
Turn on my microphone. Anna, congratulations. We all agree you passed the examination. However, we still encourage you to work very hard to finish this study.
Okay.
Congratulations.
Thank you so much, Professor.
Congratulations.
Congratulations, Arnat. And then I think that the committee members give a lot of very helpful comments, and particularly that due to the data limitations of the data sets, and then so some we probably need to probe the how useful, how feasible are the for the questions that we proposed. Okay, so you should begin to analyze to explore the data, and then we need to see what can be done and what cannot be done, okay, using the data sets. Okay, so I think that's all. So we need to take picture, right?
Yes. Okay, so
Take a picture.
please turn on your camera. Okay, so the first one, 1, 2, 3. Okay. And the second one, 1, 2, 3. Okay, thank you so much.
Thank you.
Thank
So
you.
congratulations. So Nguyen and Anna, you guys can relax for at least over the weekend. Okay, starting next week, you guys need to start working on the data sets. Okay, good. Okay, bye. Bye bye bye.哎，周老师跟那个梁老师，那个我们是不是就要不要直接？
好啊。
我们就直接进下一个，然后我看看那个，但是我们好像有点早，所以我看看要那个，如果那个谁，慧宽，如果慧宽 OK 的话，我们就可以提早，可以吗？还是要要再等一下？
那休息5分钟好不好？还是10分钟？
那这样就休息到3点半开始好不好？
好啊。
好，可以。
3点半哈，那我们
是另外一个连结，不是这个。
对，是另外一个连结，对，好，谢谢。然后那个资秀就麻烦你了哈，其他的
好，
那个
老师我待会会
文件
寄那个 email 给你们签名。
好，我们有个 e-sign，所以只要在 e-sign sign 就好了。
嗯，
好，谢谢，
等会见，
好，拜拜。